respected dignitaries on the days, ladies, gentlemen, wishing you all very happy, healthy New Year 2025. Greetings from Mangalore. It gives me immense pleasure to welcome you all to this 14th edition of Spectrum, that is Symposium on Cardiovascular Therapies and Research Update Mangalore. On behalf of the organizing committee, I extend a warm welcome to all the distinguished speakers, delegates to this scientific feat. This is the 14th edition. We initiated this program in 2012 and it has grown in leaps and bounds over the years, uninterrupted. Only during pandemic, that is in 2021, we had a virtual meet and in 22 we had a hybrid meet. Every year, the scientific content is meticulously planned for both the physicians, cardiologists, PGs of MD medicine and DM and DNB cardiology. It is useful for cardiovascular technologists also. We have different team every year, and this year the focus is mainly on the interventional cardiology updates. We have eminent speakers across the country sharing their expertise to the gathering. My pranams to our beloved chairman, President Dr. A.J. Shetty, who is part of this program since its inception in 2012. And he has inaugurated all the editions of Spectrum. Thank you very much, sir. He has encouraged and supported us all these years. He's a great philanthropist and above all, a good human being. I thank you, sir, for accepting our invitation to be the chief guest today for our function. I welcome our guest of honor, Dr. C.N. Manjunath, MP from Bangalore Rural and former director of Jayadeva Institute of Cardiology, Bangalore, whose name is resounding among the public and the medical fraternity for his profound contribution to make the Jayadeva Institute a world standard institute and helping so many poor patients to alleviate their problems. I welcome you, sir. I also welcome Dr. Prashant Malla, who is joining us shortly. I also welcome Dr. Amita Malla and Mr. Prashant Shetty in his absence for the great supports we have. I welcome all the distinguished speakers across the country, Dr. Subramaniam, Dr. Ajay Swami, Dr. Surya Prakash Rao, Dr. Chedda, Dr. Satyaki Nambala, Dr. Girish Navasundi, Dr. T.K. Venkatesh, Dr. Arun Gopi, Dr. P. Balaji, and our own Dr. Manish Rai and Dr. Premalva. I also welcome all the chairpersons, senior professors, head of the departments, physicians, PGs of medicine, and DNB cardiology and technologists. I'm sure you will be rich in your knowledge at the end of symposium. I welcome all electronic and print media also. Enjoy the scientific fiesta. Happy learning.
Thank you, sir, for the warm welcome.
Ladies and gentlemen, we are about to commence our event by lighting the lamp of knowledge and wisdom, a symbolic moment that signifies the dispelling of darkness and igniting of thought and enlightenment. I invite the dignitaries to inaugurate the event by lighting the lamp.
The best way to predict the future is to create it. Today, we are fortunate to have with us someone who has not only envisioned a brighter future for the field of medicine, but has also worked tirelessly to bring it to fruition. Our esteemed guest of honor, Dr. C.N. Manjunath. I now call upon Dr. Prem Alwa to introduce our guest of honor to the gathering.
Good morning, everybody. Dr. C.N. Manjunath doesn't need any introduction, but just for the benefit of the youngsters here who want to know more about him. Currently, he's serving as the MP at Bangalore Rural, and he was earlier a senior cardiologist and ex-director for Jayadeva Hospital, Bangalore, for last couple of decades. When he was director of Jayadeva, the institute recorded more than 500% growth, where they had initially started with 330 beds and went on to more than 1,600 beds. And he also started various other branches in Mysore, Gulbarga, and other parts of Karnataka. He's introduced and practiced his motto was treatment first, payment next concept. I don't think that we have that anywhere else. He has exclusively implemented the concept that every needy patient should be given quality treatment irrespective of financial affordability. And it's interesting that even American President Barack Obama has applauded the Institute's work under Dr. C.N. Manjunath sir's guidance. A little bit about his professional skills and achievements. He's had a new innovative technique for performing the BME, which is a balloon mitral valvuloplasty in difficult cases. It's also called as the Manjunath's technique and is also published in the American Journal of Catheterization and Cardiovascular Interventions, which is the #1 journal for interventions in the world. He's done the highest number of balloon mitral valvuloplasties with the Acura balloon and also published the same in Journal of Interventional Cardiology in 1998. The left atrial thrombus classification is called Manjunath's classification. He is an international authority in balloon mitral valvuloplasty and catheter and has performed more than 30,000 interventions, including coronary and non-coronary interventions. He's conducted 200 angioplasties in just 5 days free of cost, which is again a world record. He has more than 400 publications in both international and national journals. And there's a long list of awards that he received, starting with the Padma Shri Award in 2007, the Millennium Plaque of Honor by Honorable Prime Minister in Indian Science Congress, Mysore, 2016. He was given by the Indian College of Cardiology the Lifetime Achievement Award way back in 2016. He has received the Varsha Kannadiga Award by from the Honorable Chief Minister in 2021. The Karnataka State Rajyotsava Award in 1998, and the list is long. I could go on. He has various awards and excellence from various organizations. It's an honor to have you here, sir. Dr. C.N. Manjunath, sir.
I now request all the dignitaries on the dais to felicitate our guest of honor, Dr. C.N. Manjunath.
Good morning, ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. First of all, I'm very thankful to Sri A.G. Shetty, Dr. B.V. Manjunath, Dr. Prashant Marla, Dr. Prem Alwa for this invitation to be amongst you for the Spectrum 2025. And this has been going on for nearly, we are into the 14th edition of Spectrum. My hearty congratulations to Dr. B.V. Manjunath for pursuing and for consistently conducting this academic program for the benefit of both the general practitioners, family physicians, and also cardiologists. Actually, if you look at the very spectrum of medical profession, the landscape and the ecosystem of medical profession has gone through a lot of changes in the last 2-3 decades. So it's always very essential and imperative to know what is happening. And certainly there is explosion of technology. On one side, there is explosion of technology, and on the other side, very aggressive marketing forces. So we stand in between, on one side, explosion of technology, and on the other side, aggressive marketing forces. We stand in between, both doctors as well as patient. So the most important is the need of the hour is to provide a quality care at an affordable cost to the cross section of the society. So today what is happening, there are, in fact, we are talking about artificial intelligence, we are talking about machine learning. So amidst all these things, the clinical medicine is getting blown away by these gadgets, various technologies and all. In my opinion, despite all these things, the younger generation, because we were trained in a different time. Dr. Mukund is sitting here and Dr. Ramnath Kamath is not there. We did DM cardiology at KMC Manipal between 1985 to 88, during that period. The basics of medicine is extremely important. So today what is happening because of all these technological advances, I think clinical medicine we are forgetting. So I impress upon all the both juniors as well as seniors, we need to follow a mantra of 3 T's, very, very important. These 3 T's are important, that is talk, touch and treat. I think this is missing. Talk, touch and treat. If you follow it systematically, then the 4th T gets added, what is called trust. So talk, touch and treat. Today what is happening, we are not talking to patients and we are not allowing patients to express their symptoms, and at the same time, more often it is becoming investigational centric rather than patient centric treatment. So many times patient doesn't know who has actually treated him, because somebody admits, then somebody speaks, and somebody does the procedure and somebody gets the discharge, and they are not really synchronized or they are not connected at all. So this is where our focus should be, and at the same time, today we are having 712 medical colleges in India, 118,000 MBBS seats, and 75,000 postgraduate seats. So believe me, it is going to be a tough task for the next generation of doctors. By 2030 onwards, there will be a massive unemployment for the doctors in this country. Very, very important. So at this point of time, we have nearly 16 lakhs allopathic doctors and 5 lakhs Ayush doctors. So you can always, people talk about, no, there is shortage of doctors in rural areas, rural hospitals and this thing. But there's a maldistribution. So what is happening, there are more doctors concentrated in cities and less in village or rural hospital like primary health centers, community health centers and all. So this is where probably our focus has to. In fact, we are suggesting in the health committee, where I am also a member of the health committee, consultative committee. So even if you produce tons and tons of doctors, the young MBBS doctors are reluctant to go to the taluk hospital, district hospital. Only way we need to, of course, their salary is also too small. And what is happening, salary is small and it's just 50,000 rupees. So we have to increase the salary. There's no, unfortunately, it has not gone through. Second is other incentive that can be used to attract the doctors to the rural hospital should be, if they work, MBBS doctors work in rural areas for every 1 year of service, give some additional weightage in NEET PG examination. Give additional marks in the NEET PG examination that makes them to really work in the rural areas. So this is how we have to see. Another important thing, we are only looking at the number of, the numbers, the quality of training has really gone down. I am very sorry to say this, the clinical teaching has gone down the drain. It has become too much digital and it has become too much laboratory oriented treatment. I will just give a couple of example. How important is your history taking? See, the history taking, physical examination, and proper. If you do it properly, you can make a provisional diagnosis almost 80%. If you spend some time, if you are not allowing the patient to express their symptoms, you are virtually preventing them from telling you the diagnosis. See, on the other day, I was just to give an example, there was a patient who has been scheduled for surgery for gynecomastia. So what was happening, when somebody has taken the brief history, this patient was eating the neck portion of the chicken. He was very fond of eating neck portion of the chicken. And in that area, to make the bird grow bigger, they were injecting estrogen hormone into the neck portion of the chicken. Obviously, he was consuming the neck portion of the chicken. As a result, yes, he has developed gynecomastia. What is treatment? You should stop eating this thing. And the other example I will tell you, see, in our profession, decision making is more important than incisions. Decision making is more important than interventions. And finally, treatment should not be more harmful than the disease. So these things are very, very important. I will just, I can recall one story. I had gone to Mysore about a couple of months back for a similar program. One elderly man wanted to garland me, and the organizers were not allowing him to meet me. So then I asked, no, let him come and garland me. Then I asked, why are you garlanding me? He was telling, sir, actually 2001, that was about 23 years back, I was advised emergency surgery in some hospital. I came with an angiogram report to you. You said, your caliber of the artery is so small, you will not be benefited by surgery. In fact, surgery can be more harmful, and you just be on medication. And 23 years since then, I am fine, active, and that was the greatest decision, this thing. So this is what the importance of decision making is going to be. And another important thing, as doctors, we should understand, you understand the financial bracket, financial background of the patients, and you work out a best strategy of treatment within that financial background. I will just give an example. See, we all travel in aircraft, economy class, executive class, or first class. If something happens, if there is an air crash, everybody will die. Not that only economy class will, passengers will die. So understand the financial background of the patient, and you evolve appropriate treatment within the financial bracket. You can see this is how you should able to provide a quality care to the cross section of the society. Another important thing is, yes, today we have Ayushman Bharat scheme to support the BPL patients. So I think under Ayushman Bharat, 60 crores people in this country have been enrolled, and so far about 7 crores beneficiaries have been treated. But unfortunately, what is happening, out of 1900 cardiac I mean totally all medical procedures, only 1300 are included. Another 600 procedures has been left out of this Ayushman Bharat scheme. Yes, another important thing, the rates have not been revised in southern states. So to make it much more effective, there is a need, both central government as well as state government have to allocate more funds towards Ayushman Bharat scheme, because what is happening, many high-end interventions, the package rate is not even meeting the actuals. So to make this much more effective, and so that now what is happening, because the package rate is called HBP2 2022, it is not yet revised at all in our state, including other southern states. In some northern state it is included. So to include these additional, otherwise what is happening, the patients will come with the Ayushman Bharat card, they think everything is covered. Then they pick up a quarrel. Then we say no, some procedures are not included. Then, so to make it an universal scheme, certainly the revision has to be, implemented. So both the central government, and there is some problem as far as Karnataka government is concerned. There is a problem as far as Karnataka government is concerned. According to Government of India, the BPL cardholders in Karnataka, BPL numbers are 69 lakh families, according to Government of India guideline. But according to our state, the number of BPL families is 1 crore 15 lakhs. So almost, I think we have seen what is called in our state rich BPL cardholders. Rich BPL cardholders. So it is this rich BPL cardholders are the one who creates a lot of problems in the hospital and picking up quarrel and insisting on everything that has to be covered. So I think this there is a need to adopt. Already it is revised, but the state has to adopt the revised package rates. Why I am telling all those things? Now many private hospitals are not able to take up this empanelment because it is not working out. Cost is not, forget about profit, it's not even meeting actuals. As a result, lot of load is coming on the government hospitals. When the load is more, obviously quality will also suffer. So this is how the system need to be changed. It's very, very important. Then coming to the actual program as is concerned, today 60% of deaths in India, 60% of death in India is due to lifestyle diseases. The important players as under this lifestyle category diseases are obviously cardiovascular disease, heart attack and allied cardiovascular disease. Second is diabetes. Third is hypertension. Fourth is stroke, and fifth is cancer. Now we have added another important disease to this list of lifestyle disease, what is called screen addiction and loneliness. This loneliness, because I think now life is all about ABCD. Life is all about ABCD. You look at youngsters, teenagers, A for Android, B for Bluetooth, and C for computer, D for dance. And take this ABCD to the older population. A is arthritis, and B is blood pressure, C is cholesterol, and D is diabetes. So that's how the equation has changed in the last couple of years. So why I am telling is today 30% of deaths in India, 30% of deaths in India is due to heart attack and is brain stroke. Sorry, 30% of deaths in India is due to heart attack and brain stroke. And unfortunately, what is happening, nearly 40% of deaths is below 45 years of age. There was a time children used to bring parents for the treatment of heart attack and brain stroke. Now the landscape has changed, the ecosystem has changed so much. Now parents are bringing their children in the region, for the treatment of brain stroke as well as heart attack. Now what I am telling is, today in India, yes, what is the best treatment for heart attack is prime angioplasty and stenting procedure. That, yes, we agree. But it is not possible in semi-urban and rural hospitals. So the best suited strategy for treating brain stroke and heart attack should be what is called hub and spoke model. Hub and spoke model means the rural hospitals, taluk hospital, primary health centers, they have to give, because heart attack treatment is time driven. Both you need to give treatment in the golden hour. For every 30 minutes of delay in initiating treatment for heart attack, the risk of death increases by 7%. So we need to take the heart attack treatment to the doorsteps of the taluk hospitals. That is the only way you can save a lot of lives, because this hub and spoke model means the taluk hospital should give thrombolysis, and the preferred is tenecteplase rather than streptokinase. Then after a few hours of stabilization, they can be shifted to the nearest place, nearest city where angioplasty procedures are available. In fact, this particular hub and spoke model was introduced in Karnataka 1.5 years back when I was the director of Jayadeva Institute of Cardiology in 45 taluk hospitals. Now it is going to be extended to 90 taluk hospitals. So that is in Udupi, Mangalore area, 15 taluk hospitals. Then that is of course, in the first phase it was in Bangalore, Kagalburgi and Mysore division. Now it is being extended to Mangalore Udupi division, then Davangere Chitradurga division, then Hubli Belgaum division. Because if you look at the mortality in tier 1 cities like maybe Mangalore or maybe Bangalore, the death rate from heart attack and stroke is in a single digit, is about 6 to 7%. Go to tier 2 cities, the death rate from brain stroke and heart attack is 15%. Go to village hospital, it is touching 22%. So only way we can reduce, because if you look at the number of deaths due to heart attack and brain stroke is somewhere around 3 millions. 3 million deaths are happening due to heart attack and stroke. So we need to adopt this hub and spoke model for treatment of heart attack as well as brain stroke also. See, now at this point of time in India, we have somewhere close to 3,500 cardiac cath labs. 3,500 cardiac cath labs. So going by the burden of this disease and also the prematurity of the disease, India needs somewhere around 6.5 to 7,000 cardiac cath labs. So 6.5 to 7,000 cardiac cath labs. So certainly we need to really adopt this technology for reaching the taluk hospitals or the semi-urban. So I emphasize again, semi-urban and rural India, the best strategy of treating heart attack and brain stroke is hub and spoke model. Hub and spoke model is very, very important. And yes, today we have got lot of high-end interventions, but certainly under Atma Nirbhar, we have a lot of, a couple of companies are coming with our indigenous cath labs. So that is a great value addition to the care. But ultimately, the prevention is better than cure. Precaution is still the best. Prevention is better than cure. Precaution is still the best. So, because burden of disease is so much and the disease is so premature, I wanted to emphasize here the doctors community are becoming more vulnerable to lifestyle diseases. So there are 2 studies. The average lifespan of a modern day doctor is coming down by 10 to 12 years. See, always we are busy in conducting health camps for the public. A time has come, we need to conduct health camp for the doctors community itself. Very, very important, doctors community. So many doctors, this is because there is stress of the profession and the public expectation is too much. They want even a dead person walk home. They bring very sick patients in a dying situation. That puts a lot of stress, and these interventions also. As far as cardiologist is concerned, I wanted to just tell this particular thing. Radiation is not good actually. Radiation is not friendly. You should share radiation with your other junior colleagues and all. So then that is best. So otherwise, because this is one of the reasons why the clinical medicine has taken a back seat. So I've already said 712 medical colleges, and we are going to have a big unemployment problem after 2030. It's going to be really competitive. So certainly, so because of the burden of disease is so much, we have to have what is called medical checkup anniversaries, that doctors I am talking about, one of the most stressed community. And I think we did a study, so almost after the age of 50, nearly 30% doctors have high blood pressure. The only, because they never check their blood pressure actually. And today what is happening, our younger generation have adopted what is called no-touch method of examining patients. They are not touching them, they are not examining, everything is on monitor. I think again the basics are very, very important. And finally, we have to, adopt technology, I agree, but finally you have to see how best quality care can be delivered to the cross section of the society. And we have health schemes, but they need to be strengthened. And as far as improving the public hospital is concerned in this state and this country, one of the way, I think buildings alone cannot deliver good services, and equipment alone cannot deliver good services. The real problem country that is facing is shortage of manpower in many of the public hospitals. So our theme should move from construction to creation and creation to recruitment. So not that doctors are not available, staff nurses are not available, they are really available, but we have to create more posts in the public hospitals. Otherwise, the same system will continue. So in fact, it's a pleasure coming to Mangalore, and Dr. Ramnath Kamath is sitting among the audience. He was my teacher during my DM cardiology studies. So in fact, that's the reason today what is happening. You look at our younger generation doctors, the prescription investigation. They write more about HbA1c rather than HB. So they write. So I think the basic physical examination is extremely important. So thank you very much. Live long, live young.
Thank you, sir, for your wise words.
It is our great privilege today to welcome someone who has not only excelled in his field, but has inspired countless others with his vision, dedication, and passion. We're honored to have with us Dr. Prashant Marla, Medical Director, AJHRC. I kindly invite you, sir, to enlighten the August gathering.
Good morning, everyone. Respected dignitaries on the dais, my teachers, and all the delegates who have come for this Spectrum 2025. Firstly, I would like to congratulate Dr. Manjunath, B.V. Manjunath, for conducting the Spectrum 2025 successfully since last 14 years. And every year it is becoming, going in strength to strength. And a lot of people are getting benefited because there are the newer things which are coming into our field, which will be updated to the new generation as well as the doctors of this region. And hope this Spectrum 2025 will enlighten everyone by this end of this session. At this moment, I would like to take the opportunity to mention few things to Dr. C.N. Manjunath, who spoke about these things initially regarding the NMC problems. I think you are the right person now in the helm of affairs who can understand our problems and take it to the government, because all this while we were trying to give all our problems to the Niti Aayog and people were not really understanding the issues. You have rightly said about the NMC problems and the number of people graduating in our country. It is true that in 2030 we will be unemployment scene, which we are already seeing in the super specialty segment now. Earlier, the system was like a pyramid. Super specialists were very few who were located in the cities, and people used to cater for, patients used to go to the cities and the quality care was given. Right now, there are so many people who are passing the super specialty services, which are not having enough of employment as well as the equipment which they require to practice in this, tier 2 cities. So the hope the pyramid system exists, the number of MBBS seats and the less number of the PG seats and the super specialty seats. Again, the number of units have also increased now. They are increased about 8 units for 250 admissions, and how the 8 units can function in a week, which has got 7 days, is a really question mark. And other thing is, they say about 4 major cases has to be done in a surgical specialty per day, sir. Which each of these major cases, which we need to take nearly about 6 hours to do it. And if we have to do 4 cases every day, it is not possible to do those things. I think I would like to take you to take these points to the NMC and rectify these problems. And next is about the ABHIMATHA rates. You were there, we were working with you earlier also in Karnataka when SAST was started. It's nearly 10 years since the rates have not been revised. And you rightly said this is not practical for us, the private hospitals, to run with these rates. We request on behalf of the entire Karnataka Hospital Association to look into this matter, sir. And lastly, regarding the taxation part to the doctors, and we are treating all these Ayushman Bharat schemes at a subsidized rate, and still we have been taxed so much, and we don't get anything out of this taxation. Almost all of the doctors over here are paying about 34% tax, though we are, for an angioplasty, the cardiologist might get about meager 10,000 rupees for an angioplasty, out of which about 34% goes for the taxation itself. So I think because you're the right person, sir, so that's the reason why I've taken the courage and this platform to tell you about these problems which are facing in the our fraternity. And thank you, Dr. B.V. Manjunath, for giving me this opportunity, and hope this event will be a grand success. Thank you.
Thank you, sir.
Today we have amongst us our greatest pillar of support and our constant well-wisher, Dr. A.J. Shetty, Director of Lakshmi Memorial Education Trust. I now kindly request you, sir, to enthrall young minds with your wise words.
Good morning to all. Guest of honor, Dr. C.N. Manjunath, Padma Seva, and MP Lok Sabha, Bangalore Rural. And Dr. B. Manjunath, Organization Chairman, Dr. Purushottam, Organization Secretary, and Dr. Alva, and Dr. Prashant Marla, and members of the Committee of Sector 2025, guest speaker, delegates, doctors, and members of the media. It is my pleasure to join you for this Spectrum 2025 Symposium Cardiovascular Therapy and Research Update Mangalore, which focus both clinical intervention cardiology. This is an important, very useful program being conducted every year. Started in the year 2012, which highlights the necessity for the upgradation and spreading of knowledge in cardiology. I am proud to be part of this program. Every year, eminent speakers and delegates from various parts of India exchange knowledge and latest developments in this field are attending today's program. For example, we have with us very experienced Dr. C.N. Manjunath and senior doctors and other eminent doctors who are with us. These days, cardiac-related problems are very common both in young and old. For the treatment, there are latest equipment, advanced system of the medicine and expert doctors. To a certain extent, regular exercise and yoga also help the patient to come out from the cardiac-related problem. I help the doctor to give proper advice to the people to take good food and to take care of their health by creating awareness. The team of cardiologists at our hospital have been giving good treatment and doing good work by assisting the patient maximum extent. Dr. B. Manjunath has been working with AJ Hospital since 23 years and is organizing this program since 2012 along with his team of doctors successfully. These kind of the program help to exchange the latest developments in the healthcare system and also the post-graduation practicing doctors. I hope this symposium will shed light on all aspects and help the cardiologist physician for their professional excellence. Few eminent guest speakers are with us with rich information for the subject to share their knowledge and experience and to enrich your skill in the healthcare sector. I urge you all to make best use of this wonderful program. We will always support such kind of program in future also. I wish this program grand success and thank Dr. B. Manjunath, Dr. Purushottam, and a member of the organizing committee for organizing this program, and also thank all the participants. Thank you, one and all.
Thank you, sir.
Gratitude is not only the greatest of all virtues, but the parent of all others. I now call upon Dr. Prem Alva to deliver the vote of thanks.
Good morning again. We are deeply indebted to our MD and Chairman, Dr. A.J. Shetty sir, for gracing the occasion and being a constant support for our Department of Pediatrics, Cardiology and Cardiology. We thank our management, including Mr. Prashant Shetty, Dr. Prashant Marla, who's been a constant support for us and helping us in any problems we've had and with no interference while smooth running of our departments. We thank Dr. Amita Marla, who's the director of our hospital. She's like the invisible hand at the backbone of the hospital who ensures a smooth running by heading both the quality and the NABH team. We're obliged to our Dean, Dr. Ashok Hegde, and the Medical Superintendent, Dr. Sachidanand, for their constant support. We're grateful to Dr. C.N. Manjunath, sir, for taking time off from his busy schedule now that he also has a political career running parallelly, for accepting to be the guest of honor for today and agreeing to deliver the first Dr. S.G.S. Prabhu oration lecture here today. We thank all the speakers and chairpersons who come from various parts of the country, leaving their work, being a work day, and being here and agreeing to give the talks for today. We are indebted to all the HODs, professors and consultants of medical colleges, both in and around Mangalore. And a big thank you for the delegates. Thank you for being here. We hope it's a great learning experience for you. As usual, SHADS and A1 Event Management is doing a wonderful job today. A big thank you. We thank the print and the electronic media for covering our event. Hoshin Pearl hotel, as usual, has provided us a wonderful ambience and cuisine for this event. Finally, a big thank you for our own hospital consultants, a team for cardiology, and the MR and the entire department for helping us conduct this event. Thank you very much.
Thank you, sir.
We request everyone to rise for the national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Our next session, we will be having a short tea break of 10 minutes. The session will begin by 12:10.
The first oration of Professor S.G.S. Prabhu Memorial Oration today. We are very sad to the demise of our professor, who was a beloved teacher. He was, in fact, the teacher of teachers, because most of the teachers at present who are there at present in our fraternity, he was the teacher for us and the examiner for us. And a few of them who are present, one among them is our Dr. C.N. Manjunath, and myself, Dr. R.L. Kamath, Dr. Mukund, and many of us who feel the sadness of the demise of our professor. Dr. S.G.S. Prabhu was not only the great teacher, he was a very good clinician, very hardworking, and his only aim was to see that the students excel in their proficiency. When we all joined the KMC Manipal, he started the program in 1981, the first DM program in the Karnataka to be started by him, and Dr. R.L. Kamath was his first student. And till now the program is going very nicely, and it has brought out so many youngsters who are excelled in their who have excelled in their professional career. Professor S.G.S. Prabhu completed his MBBS degree from King Edward Memorial Hospital, and he completed a post-graduation from General Medicine from PGI Chandigarh, and he worked in London as well as in Green Lane, New Zealand. And he did his DM super specialization, DM cardiology from CMC Vellore, the prestigious institute. Afterwards, he worked in the interventional cardiology at the Green Line Hospital, New Zealand, and he has started the department of DM cardiology in 1981. Was the first student, Dr. R.L. Kamath. He was a great teacher. He was instrumental in guiding and teaching many of us who are settled now, nationally as well as internationally. And he was a great speaker at various cardiology forum also, with number of publications to his credit. In 1981, he had a gold medal given by the Governor of Karnataka, and in 1991, His Holiness Sri Sudhindra Tirtha Swamiji honored him with Vishwa Konkani Sammelana, Mangalore. And in 2005 and 2010 also, GSB Samaj, Cochin and Mumbai respectively, he was honored. He received the Lifetime Achievement Award in Cardiology also. It is our privilege to have Dr. C.N. Manjunath as the first orator of this memorial lecture, which we have decided to continue every year in Spectrum. And also we have suggested that this same memorial should be at the national level also. And we are very also happy to invite and receive his children. Mrs. Sumana is here, Dr. Saumini, and the son-in-laws, Dr. Ravindra Prabhu and Dr. Padmanabh Kamath. So with these things, I invite Dr. C.N. Manjunath to deliver the first oration. Thank you very much.
The chairpersons for this session are Dr. R.L. Kamath, Senior Cardiologist, Mangalore, Dr. K. Mukund, Senior Cardiologist, Omega Hospital, Mangalore, and Dr. Padmanabh Kamath, Professor of Cardiology, KMC, Mangalore. Welcome, sirs.
Kamath was his first student. In fact, he was assistant professor when we joined. Then myself, then Dr. Mukund, we were all together. So it is a great journey, whatever we are today. Even because many time now cardiology means basically interventional cardiology. I don't, because you look at their business card or their, card, they write interventional cardiologist. I want them to write as cardiologist because cardiologist should know everything. He should be an interventional cardiologist. He should be a basic clinical cardiologist. So now the landscape has changed so much. Today people think if you are not doing TAVI, you are not a cardiologist. So if you are not doing complex coronary intervention, you are not a cardiologist. I think when we were in Manipal, of course, it was a hard journey because anything you learn by hard work will remain forever. Anything you learn by shortcut, it is short-lived. So we had a fantastic clinical training at KMC Manipal under Professor Sarottam Prabhu. Even we have to remember Urmila Swain also, she was there at that time. But one thing, it was a very homely atmosphere. Used to visit his house at that time. Somini and Suman, they were small kids. So Madam Prabhu used to give us sweets, used to give us thing. So there was a great culture. It is not just a profession. It's not just cardiology we learn. That culture is very, very important. So I think any knowledge without culture has no meaning. So these three things were there. One, yes, we learned cardiology, and we also inculcated a lot of culture and also relationship. I think because people nowadays are respected for two things. One is for power, and second is for teaching. So power is temporary, but teaching is permanent. So that's where the great Sarottam Prabhu is remembered. And even today, see, everybody says those who have been trained from Manipal, they are good in structural heart disease, good in coronary artery disease, good in congenital heart disease, everything. So at that time, it was basically, in fact, on treadmill itself, so much is there when you start reading. Nowadays, some technician does treadmill, and 8 out of 10 treadmill is interpreted as positive, and nobody talks about false positive treadmill test. So somebody, 25-year-old female, 30-year-old female, false positive, but nobody thinks about false positive. And the way we were trained in Manipal, by the time we come to the final year, we almost had a clinical knowledge and wisdom of a consultant. By the time we come to third year, we were almost like, so that was a fantastic training. We got it. So really, we owe a lot to this great man, Professor Sarottam Prabhu, and this is where they belong to a greatest generation of teachers. So they belong to a greatest generation of teachers, and we had an extremely homely this thing. So it's my pleasure to deliver this oration. In fact, when Dr. B. Manjunath called me, I said I had some other meeting, I cannot come. But when they mentioned, no, it has to be in the honor of Professor Prabhu, I think all other things are secondary to me, because this is how we have to give something back to his great love and affection he showed to us. So I'm very thankful to in fact, I have to acknowledge the presence of his two daughters, Somini and Sumana, and Ravindra Prabhu and Padmanabh Kamath. Of course, Padmanabh Kamath, being a cardiologist, is very well known, close to us, and he is also doing a lot of philanthropic work, and he is also doing a lot of community services. So, with this, certainly it's my pleasure to deliver this lecture. In fact, I love to have given some sort of a clinical physician-oriented lecture, but Manjunath said, no, you have to talk something about atherectomy and all. And Dr. Sarottam Prabhu used to tell, I think as far as, at that time, it was all diagnostic. Even coronary angiogram was a big thing to do. And today we are in an era where contraindications have become indications. See, when we were doing DM cardiology, coronary angiogram was contraindicated for acute myocardial infarction. Today it is the indication for doing an angiogram. And we used to do coronary angiogram with a standby anesthetist. So today, I think by the time you go to the cath lab, the first year DM resident would have already done angiogram, and also you would have already done some procedure, and this is where. So I think one great thing we have learned is, see, this is what is happening nowadays. We have got very bright minds coming to all super specialities, and unfortunately, when once they pass out, they do extremely well in the examination, but after passing, they stop teaching. So I think we should never stop teaching, because life never stops. We should never stop learning, because life never stops teaching. So if you want to remain in the hearts of your students, you need to be a good teacher. So very, very important. With this, let me talk about the oration. So actually, today, as I have said, the contraindications have become indications. We never thought about a decade, 2 decades ago, whether a calcified, because two things that bother an angioplaster is, one is calcium in the coronary artery and a big thrombus burden in the coronary artery. Two things are really going to bother a coronary interventions. So, in fact, I still remember Dr. Prabhu's word, you train a donkey in a cath lab for a few years, it will put the catheter with the hind leg. That's what he used to tell. So, he was emphasizing that you learn more about basics, about the pressure tracings, and so many times nowadays, we are, of course, lot of artificial intelligence has gone into all these things. So, they take an ECG when the hands are shaking, and it is interpreted as an abnormal ECG, because the hands are shaking while taking ECG. It is read as abnormal, and straight away they go for an angiogram and this thing. So I think this is where the clinical cardiology or any clinical medicine is relevant. So orbital atherectomy is a new weapon to tackle calcification, and also let me touch upon the current status of a laser angioplasty. So coronary calcium, actually, if you look at the coronary calcium is encountered more frequently in the modern day coronary artery disease because of aging population and comorbidities such as hypertension, diabetes, and also CKD. And calcified lesions are associated with poor short and long-term outcomes. The problems of having too much of calcium in the coronary artery, there will be difficult in stent delivery, leading to either a strut fracture or polymer stripping and stent under expansion. We will not able to really properly expand the stent. So these are the practical issue. There will be a lot of difficulty in advancing the stent through the angulated calcification, under expansion of the stent, resulting in stent thrombosis, and repeated pushing of the stent can lead to a stent loss and breakage of the struts, and calcium may interfere with the imaging of the stent. These are some of the practical issues. So of course, if you look at the evolution of an angioplasty, every 5 years there is a breakthrough. So we never used to consider angioplasty for a left main disease about decade 15 years back. Now left main coronary artery disease with syntax score less than 22, I think has become a class 1 indication. So this is what the landscape of coronary intervention has changed a lot. So calcium indicates an advanced stage of coronary artery disease. And of course, we do a lot of CT calcium score. Nowadays, CT calcium score is part of mastoid checkup evaluation. But presence of calcium on CT only says yes, there is a disease process has started, but doesn't always means patient has an obstructive lesion. So calcium score, of course, if calcium score is too high, that's a different issue. Just the presence of small calcium doesn't mean always have a significant disease. Often coexist with other challenging morphologies. Example, osteal bifurcation, tortuous, diffuse lesion, and it's difficult to cross and dilate the lesion with a balloon, and there will be a decreased angiographic success. So smaller final lumen diameter and less acute lumen gain, and already some malapposition predisposing to stent thrombosis and restenosis. And most important, if there is most important thing, whenever there is too much of calcium in coronary arteries, when you are contemplating an angioplasty and stent, we need to really prepare the bed. You have to prepare the bed properly and by using various debulking mechanisms. So that should be the priority. So what are the debulking devices we have? High pressure non-compliant balloon. Of course, we have opium and all those things balloon. Then we have a cutting balloon. Then we have rotational atherectomy. Then we have orbital atherectomy, excimer laser, and intravascular lithotripsy. So all these gadgets and newer tools are available, but we need to really you should select a proper strategy of treatment. How do you assess calcium? I think this has been already dealt, and speakers also following me are going to talk about this. There could be an overlap. Fluoroscopy is easily available, specific but insensitive. IVUS is sensitive and specific. Of course, nowadays all complex interventions are always done with an imaging technique, intravascular ultrasound, and also your OCT. These are, I think, they have really added a lot of value to interventions because your understanding of your calcium, understanding of the internal morphology, understanding the depth of calcium, everything is best done with it. It is the imaging which has given a lot of information and is very helpful in really picking up a particular strategy of treatment. This is how the calcium looks on intravascular ultrasound. So whether it is 360-degree calcium, whether what is the depth of calcium, and what is the angle, all those things. So the OCT, the subtle differences between IVUS basically the depth, because its penetration is less, so we're not able to get the entire depth of calcium. So you can see, I think these are the slides in fact I have taken from our Dr. Chadda. So if you look at this, you can see here, so the calcium, we will understand all those things. So whether it's a thick plate of calcium, then the thin plate of calcium, and all those details are extremely important, whether it is a fibrous nodule or a calcific nodule, based on this, because if there is a eccentric calcific nodule, then your IVL balloon does not work. So I think all these things have been extremely helpful in choosing a proper strategy of treatment. Sorry. So, what are the principles of angioplasty in a calcific lesion? Lesion preparation. Second is plaque modification, maximizing the stent expansion. So, we need to really look at the proper lesion preparation is extremely important. As I already said, there are 4 to 5 tools that are available for debulking the calcium, because basically when once you really debulk the calcium and the plaque modification, then your stent delivery is always relatively better. Otherwise, trying to push the stent through calcium will have a lot of complications. So this is an orbital atherectomy. Orbital atherectomy, this is a system from Diamondback 360-degree atherectomy system. So I will not get in too much of technicality of this one. So we have two types of atherectomy actually. One is rotational atherectomy, and this is that is driven by gas, and that is learning curve is little longer. This orbital atherectomy is driven by an electric motor. So this catheter has got a diamond eccentric diamond crown, and it spins when this is basically drilling the coronary arteries. This is basically sanding. It causes sanding of the plaques and sanding of the calcium, and is drilling the calcium. As a result, the stent delivery can be easier. This is how, I will not get into too much of technicality of this thing, but basically it is a user friendly device. So it has got a diamond, it has got a diamond eccentric thing, and that spins at a rate of about 80,000 revolutions. With high speed it can go up to 1,20,000 revolutions, and of course all those finer details we will not get into all those things. So this is just a pictorial thing. This is how it works. So it is just there is a calcific plaque. This is how when you start moving this catheter, it causes the disruption, and also it is broken into small microparticles of maybe 1 to 3 microns. So this is how it is done. So what are the differences between rotational atherectomy and orbital atherectomy? So you look at this, of course, it is rotational atherectomy is compatible with the 0.9 wire, while this is with 0.12 wire. The rota wire is very thin. It's difficult to maneuver. You have to always do it under the cover of a microcatheter. But this is this orbital has got a little bigger dimension. And rotational atherectomy actually ablates only in antegrade direction, while orbital atherectomy it actually shaves off both in forward direction as well as in backward direction. That is the advantage. And with increasing speed, the size of the because in an rotational atherectomy, of course, we have various sizes, 1.25, 1.5. Each time, if the artery is very big, then we have to exchange for a new catheter. But with orbital atherectomy, see, if you increase the speed, the size of the crown increases automatically. So there is no need to, that is the reason this is best suited for a calcific lesion in bigger arteries. It is best suited for calcific lesions in the bigger arteries. So there is no need to change for the fresh catheter, and both are compatible with the 6 French, but certainly orbital atherectomy. And the direction of ablation, I have said, rotational atherectomy is in only in forward direction, and this orbital is, it actually ablates the plaque both antegrade and retrograde. But only thing, when you are doing rotational atherectomy, you have to move the catheter to what is called woodpecking to and fro fast, while orbital atherectomy you have to move very slowly, 1 millimeter per second, and that is one of the reason. And most another advantages of orbital atherectomy is when you are actually doing this procedure, it does not obstruct the blood flow. And the particle size with rota, it is about 5 to 6 microns. So there can be a distal embolization, there can be a slow flow, no flow phenomena. Of course, it is less, but it is relatively, it is more with the rotational atherectomy, while with orbital atherectomy, because particle size is so small, there is no slow flow and no distal embolizations. These are some of the important fundamental differences between rotational atherectomy and orbital atherectomy. So what are the lesions which are not that suitable for orbital atherectomy? In-stent restenosis and extreme tortuosity, orbital atherectomy is not the choice. And so even the in-stent restenosis, sometimes osteal lesions. So these are, of course, osteal lesions can still be done, but definitely this is not a tool that can be considered for a lot of tortuosity if it is there. Orbital atherectomy is not an option, I think. So I'm just going to show a case, 78-year-old male, post bypass status, class 2 angina and type 2 diabetes with hypertension, and for last 30 years. So clinical examination is okay, nothing remarkable. Smui? No. Hmm? It's not coming. Anyway, I think it's not showing. Of course, this case we did a EVAS also. It has almost, deep calcium. Sorry, the images are not moving. So this was a significant stenosis. Lima to LAD was functioning, and we did a orbital atherectomy on this case. It was basically 3.5 millimeter vessel. Then, in fact, initially even 1.5 balloon was not going through the ostium of the right coronary artery. Then with the orbital atherectomy, the balloon passage was smooth. Then sequential, we stepped up the balloon dilatation up to 3. Then 3.5 into 18 stent was deployed with an excellent result. Sorry, this is not moving. It's okay. Then the post stent, lumen was almost 4.2. Vartela. It's okay, fine. Let's not bother about it. Astana? It's okay, fine. Then, of course, this is how some heavily calcified lesions. So actually, in mild to moderate calcified lesion, even non-compliant balloon will work, or even a cutting balloon will work. In heavily calcified lesions, basically either we have to go for a rotational atherectomy, or maybe an orbital atherectomy, or sometimes this IVL, that is lithotripsy. But laser works only in moderate calcium. If it's a heavily calcified coronary artery lesion, the best strategy is atherectomy, either rotational or maybe orbital atherectomy. This is one of the Orbit 2 study design. They were looking at the efficacy of orbital atherectomy. It's basically concerned with the procedural success. It is not going to have any impact on restenosis, not going to have any impact on the intermediate or the long-term outcome. This is basically to improve the success rate and a successful stent deployment, and also to get the maximum lumen area. So these are some of the Orbit 2 trial. The key inclusions is the target lesion must have a fluoroscopic or IVS evidence of a severe calcium, and also the target and the calcium arc should be more than 270 degrees. The target vessel reference diameter should be more than 2.5. So this is one of the greatest advantages of orbital atherectomy. Bigger arteries with a lot of calcium, and this is the best compared to the rota. But still, of course, rota is the traditional, conventional device for debulking the calcium. And the key exclusions is those with chronic renal failure, the ejection fraction less than 25%, and target lesion in an osteal location, and the those thrombus is a contraindication, very important. So whether it is rota or atherectomy, thrombus is a contraindication. So these are some of the results. Actually, the success rate is close to 90%, and the advanced. So they have compared orbital atherectomy versus rota. There is no much difference. Ultimately, in heavily calcified lesion, the rota has achieved little better maximum stent area compared to the orbital atherectomy. Look at this 12 months amaze adverse events in patients with severe calcium. So with with atherectomy it is 14.8%, and also the 1 year follow-up, the adverse events were 16%. But with rota, that is rotaxis, but all these things has happened when we did not have third generation stent. So normally we are overestimating the adverse events, but now with the present polymer, with the present everluminous stent technology, these are all in single digits. This was because when they did this trial, they were using the tax stent or the second generation stents, and the polymer was also different. Now with the present technology, with the present stent morphology, restenosis rate is in single digit. So look at the target lesion revascularization is around 3.5% in the Orbita group, and it is around 12%. But only the reason why it is 12% with the rota is the stent used was taxus. Now we are not using it. So obviously there is no significant difference between the two. So then I will talk a little bit about excimer laser system. This is another newer technology that can be used for treating moderately calcified lesion. But one advantages of laser angioplasty is it can be done. It's quite useful even in presence of a thrombus. So this is because other devices are contraindicated in presence of a thrombus, but calcium with thrombus or with this is one of the greatest advantages for laser angioplasty. So it acts by three mechanisms. One is photothermal, second is photochemical, and photomechanical. These are the three mechanisms by which this laser angioplasty works, and very useful in patients with instant restenosis or underexpanded stent, or lesions which are non-dilatable with balloon, or where it is difficult to cross with a balloon. So this is how this basically creates a vapor bubble. And what most important thing is we have to move this catheter very slowly, millimeter by millimeter, and there should not be any contrast within the artery when you are using it. It's all saline infusion, so it should be slow, it should be saline, and this is how the laser works. So the indications is for the laser is moderately calcified lesion, instant restenosis, underexpanded stent, lesions that cannot be crossed, dilated with a balloon, thrombotic lesions, and saphenous venous graft. This is another area where it works. Normally, other devices we don't do, atherectomy devices, we don't use the atherectomies. So 6S of a laser angioplasty: selection, sizing, setting, saline, and speed. So that means suppose when you are doing a laser, if you inject contrast, then it creates a bigger bubble and it can cause perforation. That is the only thing. Of course, in some centers, if lesion is not yielding, you can inject some small contrast, but you have to be cautious. Otherwise, there should not inject any contrast in that. So you can see slow advancement is the key. Lumen diameter with a fast advancement on the left side, you will not get a bigger lumen, but slower is better. So that is the hallmark of laser angioplasty. Slower, the catheter movement should be very slow a few millimeter per second, very important, technology. Of course, I will not get into the details of fluence and rate. It has got basically 60-60 or 60-80 like that. So this is one patient who has undergone an aortic valve replacement. He also had a stent in the left circumflex. So we decided to do a laser on the left circumflex. Of course, that is a small, you can see there a small opaque thing, that is the laser catheter. Technically, it's not a difficult, but only financially it is a tough thing. So I think all these high interventions, you have to be choosy, and you have to understand, as I already said, the financial background of the patient is important. Otherwise, APL patients, by the time they get discharged, they become BPL. So when once you do a laser, many laser passes, then the lesion becomes more amenable, more softer, and your stent delivery is smoother. See, all these things, debulking device, whether it is rotational atherectomy or orbital atherectomy or even the laser, makes the life of an angioplaster more comfortable, and there will be, otherwise you will be struggling with technique, trying to push the stent through the calcium, the stent loss, and sometimes in fact you will be sweating more than the patient. So using all these devices, you are going to prepare the bed, and the next the stent delivery will be always smooth. So this is how we just did a laser passes, then the stent was deployed, another stent, and the result was good. So this is a second patient of laser, 44 years old male, inferior MI, late presentation. In fact, he presented really 48 hours after the onset of pain. So obviously you can't thrombolize, and this patient was taken for an angioplasty. You can see the right coronary injection. It is occluded in the proximal segment. Then we took him for a balloon angioplasty, and we did some dilatation. There was no flow. You can see here there is a lot of thrombus. These thrombus are more than 48 hours old. So we gave intracoronary tenecteplase. Still there was no clearance. Then ultimately we decided to do laser. At that point of time, we were not aware where laser is going to work in presence of a thrombus. So this is one actually debulking tool where it works really well in presence of a thrombus. So that opens up a new new horizon where it can be used during primary PCI where thrombus burden is high. So intracoronary tenecteplase was given, 3 runs of thrombosection, then intracoronary, so a lot of cocktail was given, but still there was no flow. So then one of our technician suggested, sir, can we do a laser? Then at that time, I was also not confident. Many a time, a greatest advice comes from the junior most people or from the technician, so you should listen. So always there's a very popular saying, we should talk in such a way other people love to listen, and you should listen in such a way other people loves to talk. So this is how the things went on. So then laser, it has this frequency fluence. See, after laser, the flow was very smooth, and thrombus was actually pulverized. So, thrombus was entirely pulverized. So this is the final result. Then, so see, the vessel became so big, and there was a very good flow, and there was no slow flow, there was no distal embolization. Then we scanned the literature. What is the role of laser in thrombus containing lesion? Excimer laser angioplasty in acute myocardial infarction, Carmel multicenter trial. 151 patients with acute myocardial infarction underwent excimer laser. Not many people thought about this actually, whether laser really works in an acute myocardial infarction. Then we scanned the literature. Then there was a great trial, Carmel multicenter trial. So maximum laser gain was achieved in lesions with an extensive thrombus, because we really spend and sweat out while doing an angioplasty in a thrombus containing lesion. We do thrombus section. We give a lot of the blood thinners and thrombolysis. But this is one great technology where it really works in presence of a big thrombus burden. And device success rate was 95%, and mortality was just 4%. Even patient presented with cardiogenic shock showed an excellent result. So, conclusion, the case selection and proper assessment of calcium may, by appropriate imaging, gives gratifying. Ultimately, bottom line is this thing, proper case selection. Many a time, when you decide, no, this patient is not suitable for coronary intervention, that is one of the greatest decision. You should just that I think this is where your wisdom, your clinical thinking comes. Whenever there is a problem, you discuss with our colleagues and come to a conclusion. That is very, very important. Adequate lesion preparation is the key. In some cases, non-compliant balloon with body wire can be a poor man's rota or an orbital atherectomy. And orbital atherectomy is a reasonable option in a severely calcified lesion. In long tortuous lesion with calcium, we are comfortable using 2 short stents rather than 1 long stent. Very important. Excimer laser is an option in moderately calcified lesion, that too with or without thrombus. And IVL is ideal for concentric, densely calcified lesion. And sometimes we need multiple tools. And finally, very important is, whenever you are doing any complex intervention, there should not be no ego battles. I think there should not, and probably you should know more about what not to do than what to do. You should know what not to do, and you should not take it as sort of a personal. When you are doing patient safety, ultimately is extremely important. So many times we spend hours and hours, 4 hours, 5 hours, and we should know when to stop a particular procedure when you are not successful. There should not be any ego battles. Know your limitations. Take help when needed. Very important. From the other colleagues, you can always take help when needed. Be ready to stop after a particular limit. So these are some of the important things we should always follow when doing an intervention. And yes, I have already said the decision making is more important than incisions. Decision making is more important than interventions. And finally, treatment should not be more harmful than the disease. Thank you very much.
Thank you.
I just wanted to share with you, once we are doing an angiogram in the cath lab. See, those days in Manipal, first year you are not supposed to enter cath lab, and you should focus on only basics and all. Nowadays, what is happening? The first month only the new postgraduates are inside the cath lab. So once we have done an angiogram for aortic regurgitation, and the heparin comes in 2 strengths, 1000 units per ml and another is 5000 units per ml. So inadvertently, the technician has given this 5000 units per ml, 5 ml, 25,000 units was given, procedure was done. We were holding this thing for nearly whole day. Then professor was there. He was telling, you people don't know this thing. Then he said, I myself will compress. So then he also compressed for few hours. Then it was not stopping. So at that time we were also. Then ultimately when we checked, so those things are very, very important. So this is how I think we have to learn from each other. That was the greatest training I got. And but the hemodynamics is the one thing we have to always keep in mind. Suppose whether it is today you talk about, I mean, the amount of training, the type of training that is going is not correct, because the industry people wants to take our first year, second year DM students, DNB students for IVAS training, OCT training, and debulk. I mean, all those things. I mean, I think probably that sort of whatever module, I mean, the training module we had. Of course, most of the seniors here have gone through the same training, because nowadays what is happening, there are more number of postgraduates than the patients actually in many places. More number of postgraduates than the patients, and actually they have got a degrees, no doubt. They have got a degrees, and their clinical exposure, hands-on experience is very, very poor, because half-baked doctors are more harmful than the disease. Thank you.
Thank you, C.N. Manjunath, for remembering our Guru, Professor S.J.S. Prabhu, who laid the seed of cardiology in Karnataka state. So many disciples have come up in life. The institution where you are working, Jayadeva, has developed exponentially. Student of S.J.S. Prabhu. You know, KMC Manipal has also grown all these orbital laser. Everything is now in Manipal, doing very well. Thank you for enlightening the local people here on a subject which is, as you rightly said. Thanks for remembering the great teacher S.J.S. Prabhu. And once again, I want Professor K. Mukund to say a few words on remembrance of Professor S.G.S. Prabhu.
Thank you, Dr. Kamath, and the organizers for giving us this opportunity. I am proud to be a student of Professor S.G.S. Prabhu. Those days were hard, but then they rewarded in the later practices that we had. Dr. Manjunath has been down to earth in all these aspects, brought down the laser down to the earth, and literally, and Jayadeva has grown so exponentially and brought every technology that is available to India almost on time. And we have all enjoyed the services that Jayadeva produced. Thanks to the government, Dr. Manjunath, for making it happen. Thank you, one and all. And I still remember Professor G.S. Prabhu's hosting us in his home, and his daughter smilingly inviting us to the coffee or even lunch sometimes. And it was like a family member we were, and wonderful days I still recall. Thank you.
Thank you, sir. And on behalf of Dr. S.G.S. Prabhu family, I thank Dr. C.N. Manjunath for coming all the way. Despite his busy schedule, he has come all the way with sheer love for his late professor and teacher par excellence. I too worked under Dr. S.G.S. Prabhu. I was there for 2 years in Manipal. What I saw in stark contrast to other hospitals is the clinical acumen and clinical training imparted. For every case, there was a lot of discussion. After that, before going to the echo room, clinical diagnosis has to be made. Working diagnosis has to be made. Only after that, patient reaches the echo room, and then later on, diagnostics. I too gained a lot from my professor, J.S. Prabhu. We will miss him. And I'm sure, as Dr. R.L. Kamath rightly said, seeds have been sown, and now we are seeing the results. All those students who were trained by him have made a great impact in the society. They have excelled in their society and their respective fields, and they themselves have become legends. And that itself is the greatest tribute to the legendary Dr. J.S. Prabhu. Thank you, one and all.
Yeah.
Thank you very much, sir. I think it is such a wonderful talk by you and remembering our Guru. And all of us as students, we owe a lot to our success. As you know that he was not only the great teacher, good human being, and he has shaped our career in such a way that, so all of us we remember him, but I remember in a little better. I just want to tell only one word about him. Although he was a great teacher, he was like a father figurely for me, because this episode, if I tell, I think you can imagine his character. So in 1991, during the entrance exam, I took the entrance exam, and after the entrance exam, I was working in Chennai Southern Railway Hospital. And after that, I received a letter from him saying that out of 125 people who have appeared for the DM entrance, you 5 only selected, you can come for the interview, a clinical interview on 17th June 1991. So when I received the letter, I was shocked because that was the day of my marriage. So my marriage was fixed. That letter came about a week back. So I have to decide to postpone the marriage, deciding tell my wife, she is here sitting, or I have to go for I have to leave the DM course. So my seniors there in railway said, you do whatever, you just write a letter to him, just see whether, and attach the invitation. So I attached the invitation and wrote to boss saying, sir, this is my marriage day, what to do? Then immediately he wrote me a letter, I'll give you one more opportunity. Other 4 will appear on 17th, but you please come on 24th. And on 24th, I appeared for clinical. Out of 5, he selected me only because it was the only one seat. So this shows that, I was nowhere in the picture. I am not related. He doesn't know who I am. I just appeared as one of the candidates from Chennai. So this shows that how much he cares for the persons, and he was impressed. So therefore, he took all the way this liberty of calling me second time. So I owe him a lot, and he is really, truly a father figure for me. Thank you.
Thank you, sirs. As a token of our love and gratitude, I request Dr. R.L. Kamath, Dr. K. Mukund, and Dr. Padmanabh Kamath to hand over the oration present, the memento, and certificate to Dr. C.N. Manjunath.
Intervention cardiology. He is the national proctor for complex coronary angioplasty, leadless pacemaker, structural heart disease, peripheral interventions, and heart failure device. He is a recipient of numerous awards and honors. He has got a lot of publications. Among them, 55 are national, 32 are international. He has written in many books, which includes 11 prominent books. So, over to Dr. Cheddar for today's talk.
Thank you, Dr. Prabhakar, and thank you, Dr. Manjunath, for giving this opportunity. I'm going to talk about making things simple using the modern set of PCI. We know that PCI has evolved, as you can see on the screen. It started with plain balloon angioplasty, and every year passing by, we are adding more and more tools, and they have been supported aptly by certain trials, and I'm going to emphasize on 2 trials which I feel are important trials, and I make you understand them because they tell you that the most important thing in the modern PCI is to see. That means you have to evaluate the lesion with physiology, with imaging, prepare the bed well, because if you don't prepare the bed well, your stents are not going to expand. If your stents are not going to expand, the patient is going to come back. So this is the basic mantra of angioplasty: bigger the better. If you leave the stent well deployed, well expanded, your patient is not going to come back to you. Well, let's look at how do you see. Now, it's very important that we use certain tools, and physiology is very, very important. And I quote here the Syntax 2 trial. This was a trial in which they had patients of triple vessel disease, and they decided not to use pure angiography. They decided we are going to use coronary physiology. IFR, FFR was done for the same, and almost 31 patients were taken out of the angioplasty program. That means 31 lesions were deferred. They were not given stents. And what did we notice compared to Syntax 1 trial? We noticed that the lesions less number of lesions were treated, less number of triple vessel disease were treated, and we had significantly lower number of patients undergoing PCI. So if you apply physiology, you do appropriate stenting. You are weeding out the patients who do not need stents. What did the long-term follow-up show? Now, if you compare these two Syntax 1 and 2 PCI arms, you see the separation happening at 1 year, and it's getting wider as the time goes by. So that means less number of patients treated, but you have chosen those patients who needed treatment, and the results are there to see. The gap between these two lines is widening. The patients having adverse cardiac events are much lesser in appropriately selected group. Now, when we do the comparison of this with CABG in Syntax 1 was far superior to angioplasty. There were multiple reasons for that. But if you compare Syntax 2, that means patients who have been appropriately selected and then compared with the CABG, there was no difference. That means if you use your tools well and do angioplasty, your results are going to be as good as what you get from CABG. Now, I bring into context one case. We often feel that when we do the angiogram, we can see it all. And this was one of my workshops in Nagpur. There was a OM lesion, as you can see here. It looked like a garden variety lesion. We didn't think there's nothing much in this. And this was towards the end of the day. But despite using a guide extension here, nothing would cross. Just nothing would cross. This was an uncrossable lesion. We had a beautiful talk from Professor C.M. Manjunath about calcium. Calcium is enemy number one. You know, it kind of leads to a lot of problems, and especially if you're doing the last case of the day, and if you get a case like this, there is problem. Why? Because you will neither be able to dilate, and even if you have pushed a stent inside, which is a crime I feel, because you leave the stent underexpanded, this patient will wake you up. If you've deployed a stent in a calcific milieu without preparing, you are sure enough to be woken in the middle of the night, and you have nothing to do then, because the patient will come back with stent thrombosis. Angiogram has got its limitations. It will not show you all. It will show only about 38% of calcium. So you need additional tools, and IVUS is one of the most sensitive tools. It shows you calcium. It shows you whether you prepared this calcium well or not, and post-preparation whether you've implanted the stent appropriately or in a manner it should have been implanted or not. So everything you'll be able to see if you have an imaging device, and IVUS is much superior in that regard. You have an IVUS scoring system. I'll not go into the details, but what this scoring system tells you is that you need to grade. You need to select your tools, and it helps you select your tools. Now, if you score the lesions from 0 to 4, depending on these 4 characteristics, since we are running late, I'll not go into details. If your atherectomy score is anywhere above 2, you need rotablation, orbital, or IVL to crack this calcium. So it's a very simple way of risk stratifying calcific lesions, and we must always do the same. Now, what does, in addition, IVUS tell us? This is from IVUS XPL and the ultimate trial. If you have used the IVUS optimization criteria, your event rate, cumulative event rate is very low. So it is very, very important to image and to see whether you have opposed your stents well, expanded your stents well or not. And we have more than enough data available in this regard. And no wonder 2024 European Society of Cardiology guidelines have given the appropriate recognition to imaging as it deserved. It has been made class 1A. Now, there are different imaging tools. What does American College of Cardiology say? That all labs should have imaging tools, and intravascular imaging is essential adjunct to complex PCI. You need to be educated to reach there, and if we have to choose, they recommend IVUS as a much better tool to have because of its greater potential of usage in patient subsets and lesion subsets. You can do it in the osteal lesions, you can do it in patients with renal failure, you can do it in CTO segments. See, these are the places where your OCT is not going to work. So 5-year follow-up of Syntex 2 taught us, select your lesions using physiology, do kind of complete revascularization, and if you've done that and implanted your stent using imaging, you are assured of good results. And this was the trial which used the 3rd generation stent, which has got thinner struts, has got abluminal biopolymer, drug coated, abluminally coated drug with bioresorbable polymer. Well, we also need the atherectomy, and I told you IVUS is a wonderful tool. It tells you the severity and distribution of calcium. You need to prepare this calcium using cutting and rotational atherectomy tools, and if you select that, how do you select that? If the calcium plate is thinner and it's more circumferential, cutting balloon can be used. If it's an uncrossable lesion, you will use rota. And if you have a larger vessels, ACS, MELU, then you can use IVL. IVL can also be clubbed along with the rotational atherectomy. How does rota help? It kind of reduces the trauma to the vessel. This is what happens in balloon angioplasty. You severely dissect the vessel. If you use rota ablation, you will have a very clean vessel and you will finish your procedure very well in time. And you are also assured of good MSAs. So what we did, we kind of jammed the microcatheter because nothing was crossing. We crossed with the rota wire and we rotablated this segment. It took us some time. We used a 1.25 burr. And after the rotablation was done, we cut the lesion with Wolverine. This was the post-atherectomy run. I'll save time. I'll show you. This was a thick plate calcium. These are displaced fragments. You have cracked, you've broken, displaced everything. And this brings into context the cutting balloons. Now these are specialized balloons with heterotomes. They work in both concentric as well as eccentric calcium. Now what they do is that they crack the same plate with much lesser force. As you can see here, in a NC balloon, you need almost about 3 folds higher pressure, which is delivered circumferentially, whereas heterotomes give a very high pressure at a very small area, and the intervening balloon then goes to high pressures and cracks. So it kind of holds it there, and you crack the lesion very well to produce good results. Well, this was proven in the COPS trial. We have known that at lower pressures, you get good MLAs, you get fractures, you get circumferential luminal gain using cutting balloons, and it's a tool to depend on because we know that in a calcific milieu, dissections and fractures only lead to stent expansion, and this is a balloon which is capable of producing that. Once you prepare the bed, you need stents to deploy. The Synergy offers you a good stent platform. It's got thinner struts with exceptional radial strength. It's got enhanced visibility, minimal recoil, and very exceptional expansion kinetics. So this is a stent which is more flexible with lower profile, more trackability, and lower entry profile as well. Well, the lesion was stented with the Synergy stent, and this was the end result. What looked like an innocuous type A lesion led to so much of tools being used. The other stent, I think Dr. Girish is going to cover all this, but this is one of the most beautiful stent meant for calcific milieu and proximal large vessels. The design has been changed so that there is no longitudinal shortening, and this can go to very higher limits. Why Megatron is popular? Because it's got maximum visibility compared to other stents. It has got lesser tissue prolapse because it scaffolds, and large side branch access is available. It can go up to about 5 millimeters. It's got unmatched expansion. It's best in class radial strength. So it's a beautiful stent. Just a word about drug-eluting balloons. These have become very popular. You need to deliver the drug using an expecient. Expecient enables the drug to go across to the media where the atherosclerosis generally starts. I'm not going to go into the details. There are a lot of pros and cons for doing this. DCBs don't have a class effect, so you have to choose your DCBs well. Multiple DCBs are available from different companies with different strengths and two popular drugs being used. The most important thing is to prepare the bed well. If you prepare the bed well, the DCB is going to work well. Plaque modification is very, very important, and in this regard, drug-cutting balloons are very important. I'll not go into the details, but the essential difference between paclitaxel and sirolimus is that paclitaxel is very highly lipophilic, gets absorbed very fast, and it reaches the adventitia much faster. Whereas sirolimus has got more or less a uniform distribution. It's cytostatic, the other one is cytotoxic. This paclitaxel has a very narrow window, but there's a lot of work which is on different formulation, different ways to deliver these two drugs are coming on. The strengths are varying. So, I mean, the final verdict is still not on, but at the strength at which we need them in the coronary vessels, both the drugs are equivalent. You don't get the cytostatic or cytotoxic properties of either of them coming in. Now, DCBs produce late lumen enlargement, and they produce good results provided you've optimized the lesion, you've used the appropriate DCB and inflated it for a little longer time. If you can see from this study, they clearly showed that non-optimized lesions where we put DCB do not translate into good long-term results. I'll skip this. To conclude, I would say that the modern PCI has to be done with the mantra of see, prep and treat. Physiology should be used to select the lesions to be treated, and imaging should guide us. It tells us about the plaque morphology, it tells us about the appropriate size of the stent to be used. Stent failure still remains a big challenge. You know, despite all this, there are other factors which come into play, but at least at your end as an interventionist, you should do appropriate stenting in a manner it is required to be done. Every time you have a therapy failure or a stent failure, you don't have to rush in and put another stent. Drug-coated balloons are emerging as a very good option, and you should utilize them appropriately. Thank you so much for patient hearing.
Thank you, Dr. Chadha, for explaining the devices available in the view of angioplasties. The first angioplasty, which was done by Goodzing in September 1977 in Zurich, it was a simple balloon angioplasty. So over a period of almost 50 years, so many new devices, new therapies are started, and it made the life of intervention cardiologists very easier. And I know you also mentioned that bed preparation is the most essential part in the successful angioplasty and the outcome of the long-term outcome in the primary or any types of angioplasties. So whether we are going to have a question at this moment or next?
Yeah,
okay.
Yeah, thank you.
So
Next, I call upon Dr. P. Balaji, Senior Consultant Cardiologist, HOD of Coronary Care Unit, Madras Medical Mission, Chennai, who will be enlightening us on modern age HD IVUS with AI for modern PCI strategy. Welcome, sir.
Respected moderators, delegates, thank you, Spectrum 2025 organizers, especially Dr. B.V. Manjunath for having me here. Maybe Dr. Chadha has set the stage for me. I'm going to talk on modern age HD IVUS with AI for modern PCA strategy. Of course, we have robust data to show that image-guided PCA is superior to angio-guided PCA. We have landmark trials. But is that enough? Because most of the time, we don't use image in our routine intervention for the simple reason we don't have time. You know, if you do the case at the end of the day, probably, you know, we don't have time to use the image unless it is warranted in complex PCI. But the Boston has introduced the IVUS way back in 2000 from Clearview to the present day Avigo Plus, about which I am going to talk in detail, from Atlantis catheter to present day Optic Cross HD and improved Optic Cross. The improved Optic Cross catheter is manufactured in such a way it can be maneuvered in tortuosity, calcium and whatnot without having an impact on the imaging. What are the important key features of this new IVUS from Boston, the Avigo Plus multimodality guidance system? The key features, I would say, the automated lesion assessment, which is an AA-based assessment. As soon as you do a pullback, you'll have to click on the ALA. I would show a demonstration of the video of how do you do that. It gives us the lumen and vessel borders on every frame. And the other important key feature of this Avigo Plus is the fast pullback. You have 7 pullback speeds from 0.5 millimeter. The previous year's IVAS mission had only 2 options, either 0.5 or 1 millimeter. The pullback itself will take longer time, especially we are going to use an IVAS for a complex bifurcation PCI. So probably, I would recommend that, we use a lower speed pullback 0.5 millimeter for assessing the lesion, and for the post-op optimization, probably you can use a fast speed, because what we need to understand is whether the stent expansion is good, whether the molar position is there or not, the edges are fine or not. And the third important one, we always feel that, for physiological assessment, as Dr. Cheddar told, not that every lesion has to be stented. Probably you can do a physiological assessment and need not use the pharmacological agent adenosine, the DFR. All these years, the erstwhile IVAS missions, the DFR has only had a static DFR. We did not have a pullback EFR. The Avigo Plus has got the ability to give us a physio mapping. It can give us a pullback DFR, where in which we can assess the diffuse lesions where there is a significant drop in PDPA. We can select the site and then stent it. And the last one is the table side control. Even though it's not of use in our country, the Europe and US, where the operator is controlling the cath lab missions, this comes as a great boon to them, because they can control the imaging, they acquire the image, and if needed, somebody from the control room can operate and acquire the images. So the Avigo Plus, you have got the system flexibility. You can either have a mobile cart or integrate it to our cath lab. These are the important components, of which I will say 2 of these are important. The LCD monitor display 21 inches available, which is the only one available with the Polaris. But this Avigo Plus has got another docking tablet, which is a 13-inch screen, which can be used for image acquisition, operation, as well as removed out of the machine and analyze the image offline. So this is another advantage of this Avigo Plus multimodality system. And the other one is, it has got a single power on and off. Those are all simple. The third one, the fast pullback motor drive unit, which is attached to the permanent sled, is another advantage of this Avigo Plus. So most of the time we take much of the time in fixing the MDU with the disposable sled. Most of the time our disposable sterile bag, interferes with the pullback system. But the permanent sled to which the fast pullback MDU attaches, quite shortens our procedural time. So I will talk about the ALA, the automated lesion assessment, which is a AA-based machine learning, by which the machine, once you do a pullback, it gives the vessel and lumen borders on every frame, vessel and lumen area for every frame. The vessel profile, the geographical representation of the average vessel and lumen diameters are shown. The minimum key frame marker, once you do a pullback, once you click on the ALA, it gives, this is what is the minimum key frame marker. It identifies the lumen with the least area, plus minus 5 millimeter from the key frame marker would be the MSA with the least area. It also gives us the proximal and distal key frame marker. They name it as proximal and distal key frame marker, which is nothing different from the reference segment which we used to call with our previous IVAS images. So it automatically selects an area where the block volume is less than 50%. We all know the success of a long-term outcome with angioplasty, the rule of 5 we say, if the stent diameter is less than 50, the lesion block volume at the edges are less than 50%, and the area is more than 5 in a non-left main, probably the long-term outcomes are better. Suppose the IVAS mission, the ALA, is not able to identify area with less than 50%, it will give the proximal and the distal most point of the pullback as the proximal and distal key frame marker. This is a video which will show how do you do this. That is what, after you do a pullback, this is what, you get a cross-sectional and longitudinal view. And once you click on the ALA, it automatically gives the all the minimum key frame markers, proximal and distal key frame markers with the area for each frame. You can just scroll the cursor and you will get all the key frame markers. How did they arrive at the agreement of machine learning and automated lesion assessment? This is a landmark paper by Matsumura, Gary Mintz et al. In JACC in March 2023. This ALA was developed basically using 8,076 IVUS cross-sectional images from around 234 patients, and its performance was validated with an independent 437 IVUS cross-sectional images from 92 patients. And it was shown in this paper that there is a 92.4% agreement between the ALA and expert for balloon sizing of the lesion preparation. Not only that, for each lumen and vessel area, the correlation coefficient between ALA and expert and between two expert cardiologists is more than 99.5%. And the most important is to get ALA and the features associated with the ALA like vessel profile, keyframe markers and length management. Probably you should use an automated pullback. If you do a manual pullback, the machine will not give ALA. And also, like rendered stent in OCT, where you will have a markers for the borders. If you want to have a border display on, it will show the lumen and the vessel border. But if you can have a border display off, you can assess the lumen without borders to characterize the lesion. Low confidence border. This is one of the limitations of IVUS in with Polaris. The image given, sometimes it can be because of the artifact or commonly because of the calcium dense lipidemic pool, and if the patient has got multiple stent layers, the vessel border will not be seen. But the ALA gives an automated dotted border of the complete lumen as well as vessel border. So additional features, I don't know whether the video is going to play. It has got the feature of screen capture. This is another important modality available with the AVIGO Plus, because the image system, once you want to prepare a lesion presentation, the screen capture can be directly exported as a raw data incorporated into a PowerPoint presentation, and without much delay you can start presenting. And if you want, similar to OCT, you can rotate the longitudinal view and keep it at that point. You can pinch and zoom the lesion. Once you pinch and zoom, the vessel border and the lumen border gets distorted. You can always restore it by the switch which comes up, pops up automatically. So as I told you, the range of pullback speeds, it is very, very important, I believe, especially when you do a complex multi-vessel PCA, bifurcation PCA, where you are going to have 4 to 6 runs. The fast pullback quite shortens our time. It is from 0.5 to 8 millimeter without compromising the quality. If you look at the frame rate, it is 6,000 frames for 0.5 millimeter and 375 for 8 millimeter. And most importantly, the difference, the size between the each frame for 0.5 millimeter is around 17 microns. For 8 millimeter, the distance between the each frames is 267 microns. That means even with the fast speed, it only misses 0.26 millimeter. So probably even if you do a fast pullback, we are not going to lose the image quality for assessment. Automatic pullback, as I told you, it is important for vessel profile, and always connect the motor drive unit to a permanent sled, not to a disposable sled. Coming to physiology, physio mapping, as I told you, it allows for continuous DFR measurements. Once you put inside the Comet 2 wire, connect to the AVIGO Plus machine, you will get two things. Either a DFR trend line, what they call is a 4-beat maximum DFR plotted on a solid line. So this means it averages the 4-beat, assesses the PDPA and gives us a solid line at the top, you could see. And this is most commonly used in a diffuse lesion, and you assess the delta drop. Wherever there is a significant drop in PDPA, you fix the spot stenting, redo the DFR physio mapping, you will know that whether we need to do further or leave it for medical management. Of course, the single cycle DFR is for beat-to-beat assessment of PDPA, which is not used for routine clinical interventions. It is only for research purposes. Of course, table side control, we don't need to know in our country, but in case if it comes in future, it can be integrated to the cath lab as well as control room. What is interesting is both the AVIGO Plus tablet, which controlled from the control room as well as the table side control or mirror images, and either one can be used to operate the system, acquire the image, analyze it. So what the ABHIGO Plus has done, it has shown to reduce the procedural time by 62% because it has got a shorter system boot up time. IVS pullback time is quite fast. The image assessment because of the ALA reduces the procedural workflow time. Tips and tricks. You can assess the stenosis percentage easily. You mark the reference frame and then you select the reference area, you mark it, the lumen area of the reference segment will come. Then one pop-up will come as mark reference. You select the mark reference, go to the point where you need to assess the stenosis percentage, click on the mark reference, you will get the stenosis percentage compared to the reference segment. So this was clearly spoken by my previous speaker. You should see, assess the physiology, see the image, prepare the lesion, treat it with the modern stents. Of course, FFR is to know whether to treat a lesion or not. IVS is to optimize the stent for long-term better. I will show a couple of cases. I think we had only demo, we were learning ABHIGO Plus, of course. This is a 53-year-old male, anterval MI, angioplasty to LAD done elsewhere, moderate LV systolic dysfunction. You could see he has got a significant OM lesion as well as osteal LCX lesion. We did a pullback IVS from the LAD. You could see the ALA shows an area of 3.54 compared to 9.34 of the reference MSA. So we post-dilated this. We did IVS pullback from the OM. And as I told you, you can edit the frame markers. Not necessarily the ALA is going to give the right. If you have doubt about the ALA, you can always adjust the minimum marker. It has given us 4.24. We adjusted the significant lesion site. The area was only 3.2. The plan was to stent the OM and leave the proximal osteoproximal circumflex for either a drug-coated balloon. That is what is our plan. We always, when it is planned for a de novo vessel drug-coated balloon, I used to do a cutting balloon because cutting balloon always cuts and limits the dissection, chances of dissection, unlike the semi-compliant or non-compliant balloons. And once the stenosis diameter is less than 30%, you can end up with a drug-coated balloon. So this is the final pullback from the IVS. If you see, we started off with an area of 2.8 and the final area osteal circumflex was 4.08. So this is a final result. Of course, there is a residual stenosis, but if it is less than 30% by your IVS imaging, you can leave it off because the long-term outcomes are better if it is less than. Second case, chronic coronary syndrome, significant single vessel disease. IVS pullback of the LAD shows a critical lesion abutting the LAD. The pre was not 6.2, it was less than 4. We did stenting. The final IVS, it was 9.27. So this is my last case, acute coronary syndrome, anterior wall, You could see a osteoproximal long disease. IVS pullback showed a key minimal lumen area of 2.4 at the key frame marker. The reference proximal and distal reference was 7.22. We stented from left main to LAD. We could not show the ALA for this case. The ALA, the final MSA was more than 8 for the LAD and more than 12 for the left main.
Thank you, Dr. Balaji, for an excellent talk on IVS, especially the high definition IVS. And yesterday we had a demo by Dr. Chadda in our hospital. So it is now compared to the old generation, it has made a very, it has got a lot of features which was the drawbacks was the earlier vision. So we'll have a questions in the next. Thank you. And next talk by Dr. Arun Gopi on calcium management using the rota cut approach. Dr. Arun Gopi. Arun Gopi is, he had done his MBBS from Government Medical College, Trivandrum. Presently, he is the head of the Department of Electrophysiology and Director of Cath Lab and Consultant Cardiologist electrophysiologist, Metromed International Cardiac Center, Kozhikode, and he had his MD Medicine from All India Institute of New Delhi, DNB from Sam Moss.
What is the purpose of a stent? Open the block and give acute scaffolding so that the vessel does not collapse and close. And what is the long-term purpose? There is least tissue regeneration, thrombosis. So you need to have both those benefits. The need for continued innovation, what's been the challenge? Physicians kept telling the industry and the engineers, we need better stents which can behave like this. Interventional cardiologists voiced the need for better stent for large proximal vessels than what's available current generation DS. So what did they come up? What was the need? High radial strength and axial strength. What is radial strength? When the vessel is expanded by a balloon, the stent, once it expands,